Hello everyone, today we'll be talking about volatile alcohols and this will be a little bit more detailed than my previous lectures. Please review my earlier lecture on osmolar gap and basics of toxic alcohol ingestion to get started. Ethanol is the commonest ingestion. Ethanol is metabolized by alcohol dehydrogenase and is converted into acetyl-CoA in subsequent steps. Acetyl-CoA is usually used by the citric acid cycle to make energy. However, in case of excess ethanol intake, you have excess of acetyl-CoA and excess of NADH, and thus overwhelms your citric acid cycle. So acetyl-CoA is diverted by thiolase to formation of keto acids. Since you have excess of NADH, this reaction shifts your acetyl state towards excessive production of beta-hydroxybutyrate. In glycolysis, pyruvate is converted into acetyl-CoA. Since there is an excess of acetyl-CoA, some of the pyruvate is diverted toward lactic acid formation. So you get an anion gap from acetoacetate, beta-hydroxybutyrate, and some lactic acid. Acetoacetate is your urine ketone test and your beta-hydroxybutyrate is your serum ketone test, and this causes your alcoholic ketoacidosis. Methanol is commonly present in moonshine and sometimes present in antifreeze, de-icer, and wiper fluids. Methanol is metabolized by alcohol dehydrogenase again into formaldehyde and formic acid, which are toxic byproducts. These compounds impair oxidative phosphorylation and accumulate in retina and cause retinal injury. These are also implicated in basal ganglion hemorrhage. So patients present with visual blurring, you can observe for mydriasis. Blindness can be permanent in around 10% of these patients. These patients also have encephalopathy and abdominal pain. Formic acid causes your anion gap metabolic acidosis and results in co-small breathing. Methanol by itself is not cause of the injury, it's the metabolites, formaldehyde and formic acid, that do the damage. One of the principles that you have to understand in all the alcohols is small and neutral molecules can easily cross cell membrane because your cell membrane has membrane potential. So in this case, formic acid is able to cross the membrane while your formate ion cannot enter the cell. And once formic acid enters the cell, this is the cause of your toxicity. So excess of H plus ion will stimulate this reaction towards the left to formation of formic acid and thus more toxicity. On the other hand, alkalinization by sodium bicarbonate will keep the acids deprotonated and therefore out of cells. So try to maintain your pH more than 7.35 if able. Methanol is completely metabolized by liver and half-life is around 20 hours. If you have concomitant ethanol ingestion, half-life can be prolonged up to 80 hours. You have to understand that early in the presentation you will have large osmolar gap with minimal anion gap. However, late presentation you will have smaller osmolar gap as methanol has been metabolized to formic acid and has caused large anion gap now. The most important thing in methanol ingestion is use of fomepizole, which inhibits your alcohol dehydrogenase. As you can see, fomepizole will be useful if methanol has not been converted into its toxic metabolites. So check for methanol levels, and if it is more than 20 mg per dl, give fomepizole. However, this test is not timely available, so look at your osmolar gap, and if osmolar gap is more than 10 with history of methanol ingestion, fomepizole is indicated. Give folic acid, which would help conversion of formic acid into CO2 and water. We already talked about alkalinizing the serum using sodium bicarbonate so that to keep the formic acid in its formate ion form. Try to prevent acidemia at all costs, and this is very important when you are planning to intubate a patient. Always maintain a high minute ventilation in this patient and try to attain respiratory alkalosis. Always double check your respiratory rates. If you have not given this patient sufficient respiratory rate and your minute ventilation is low and you are causing respiratory acidosis as your reaction is towards formation of formic acid which can enter the cells. Hemodialysis should be considered in all patients with methanol ingestion. Mortality is pretty high if your bicarb is less than 10 or pH is less than 7.1 at presentation. Think about hemodialysis if there is too much ingestion or formation of toxic metabolites. So methanol levels more than 50 mg per dl if no fomepizole is used, or more than 70 mg per dl if fomepizole is used are indication for performing hemodialysis. You can figure out if there is formation of toxic metabolites if your pH is less than 7.25, which can result in anion gap of more than 24, or you have symptoms like visual abnormalities, coma, or seizures. Renal failure is another indication for hemodialysis. Understand that methanol level of 50 mg per dl will increase osmolar gap by 15. So this is an easy number to look at for making a decision about hemodialysis. Intermittent hemodialysis is better than CRRT. However, if no hemodialysis is available, you can use CRRT. This figure shows that the rate of clearance of methanol using intermittent hemodialysis is much faster than when using CRRT. Since dialysis is relatively less effective in removing vomit, make sure that you continue to use fomepizole or ethanol and adjust the doses of these medications since these are dialysable as well. You can stop your hemodialysis if your methanol levels fall below 20 mg per dl or decrease in osmolar gap to less than 6. Systemic anticoagulation should be avoided during dialysis in methanol poisoning because it may increase the development of severity of intracellular hemorrhage. Ethylene glycol is the main component of antifreeze. Ethylene glycol is converted again by alcohol dehydrogenase into glycoldehyde and subsequently formation of glycolate, glyoxylate, and finally oxalate. These compounds impair cellular respiration. Oxalate combines with calcium to form calcium oxalate and can cause crystalluria, which can cause flank pain and hematuria. You can look for either dumbbell-shaped calcium oxalate monohydrate crystals or rhomboid-shaped calcium oxalate dihydrate crystals in the urine. Hypocalcemia, though can be present, is relatively uncommon. Crystals can deposit everywhere and these are the main cause for injury. You can have renal failure, cardiac failure, and neurological dysfunction by deposition of crystals in these cells. You will have anion gap from glycolic and oxalic acid and will result in Kussmaul breathing. One thing to understand is most analyzers use levulactate oxidase method to measure lactic acid level, and glycolic acid cross-reacts with this and can spuriously give you high lactic acid levels, so be cognizant of this fact. Ethylene glycol half-life is around 5 hours and 80% of this is metabolized in liver and 20% is excreted unchanged in the urine. If you are taking with ethanol, the half-life is around 15 hours. To treat ethylene glycol ingestion, give fomepizole if your ethylene glycol levels are more than 20 mg per dl, and again this number is usually not available timely, so look for history of ethylene glycol ingestion, or if you have osmolar gap more than 10 and you have oxalate crystals in urine. Since the toxic doses is around 60 mg per dl, this should increase your osmolar gap by 10, so this number is easy to remember. Use your sodium bicarbonate. This will keep the acid into their ionic form and therefore out of the cells. To get rid of calcium oxalate crystal, use volume expansion and diuresis. Use thymine and pyridoxine as these can help convert glycolate and glyoxylate into less toxic compounds. And finally, think about hemodialysis. Mortality is pretty high if your bicarb levels are less than 5 or pH is less than 7.1. Most of the compounds in this reaction are dialysable. Again, intermittent hemodialysis is better than CRRT. So think about hemodialysis. If there is too much ingestion, that means your osmolar gap is more than 10 if no fomepizole is used, or osmolar gap more than 50 if fomepizole has been used. Or you can have formation of toxic metabolite, which will be seen if your anion gap is more than 25 or pH less than 7.25. Patients with coma, seizures, and renal failure should also undergo hemodialysis. You may stop hemodialysis once ethylene glycol levels are less than 25 mg per dl or anion gap falls less than 18. Propylene glycol is the vehicle in many drugs, mostly lorazepam, dilantin, phenobarb, and IV nitroglycerine. It's also used in silver sulfadiazine cream, which is used in burn patients. Propylene glycol is metabolized by alcohol dehydrogenase into lactaldehyde, which further converts itself into lactic acid. So you get a large anion gap from lactic acidosis. Other symptoms include refractory hypotension and renal failure. Half-life of propylene glycol is around 2 hours. 60% of this is metabolized in liver to lactic acid, and 40% of it is excreted in kidney unchanged. Since most of the propylene glycol toxicity comes from your iatrogenic means, avoid propylene glycol more than 70 mg per day or 3 mg per hour. Ask your pharmacist how much propylene glycol is in the medication. And if the patient has renal or hepatic dysfunction, understand that lower dose is required for the toxicity. If you're using IV lorazepam drip, make sure that you use less than 166 mg per day or less than 7 mg per hour. Screen for osmolar gap if you're using more than 1 mg per kilogram per day of lorazepam. If your osmolar gap is more than 10, it suggests toxicity. In ICU, a lot of patients have renal failure, so avoid using lorazepam drips unless there is no other option. Midazolam is much better option in these patients. Also be cautious when using metronidazole, as this medication can impair aldehyde dehydrogenase and can result in accumulation of propylene glycol. Also, in burn patient, be cognizant that too much topical silver sulfide agent can result in propylene glycol toxicity. Isopropyl alcohol or isopropanol is the common ingredient of rubbing alcohol. This is metabolized by alcohol dehydrogenase into acetone. The only symptom you have is ketonuria, and these patients have fruity smell. So you get a triad of increased osmolar gap, no acidosis, and ketonuria. High levels of acetone can falsely elevate serum creatinine if you're using colorimetric method to measure it. So you might see high serum creatinine in these patients with normal BUN. Isopropyl alcohol is mostly metabolized in liver to acetone, and only 10% of it is excreted unchanged in the urine. Half-life is 3 hours. Since acetone doesn't cause a lot of problems, you don't have to use fomepizole in these patients. However, you can use hemodialysis if you have a very high isopropanol level, more than 200 mg per dl, and hemodynamically compromised patient or patient in coma. Gastric lavage is not usually helpful in alcohol ingestion, as the absorption is rapid and is complete in 30 to 60 minutes. Intermittent hemodialysis is better than CRRT. However, if you do not have hemodialysis, use CRRT. Use serum osmolar gap to follow the levels of parent compound, and use anion gap to follow level of subsequent acid metabolites. The key clinical differentiating feature between the 5 common alcohol ingestion is the type of ingestion. Methanol is seen in adulterated alcohol, ethylene glycol in antifreeze, propylene glycol in IV drips, and isopropanol in rubbing alcohol. Methanol, ethanol, ethylene glycol, and propylene glycol result in acid formation. You will have anion gap acidosis, while isopropanol overdose will have no anion gap. However, if you are presenting very early in the course, you will not have any anion gap in either of these 4. Try to remember the differentiating clinical features between these 5 alcohols. Patients with methanol will have visual problems. Patients with ethanol will have high levels of beta hydroxybutyrate. Ethylene glycol patients will have calcium oxalate crystals. Propylene glycol will have high lactic acidosis, and isopropanol ingestion will have ketonuria but negative beta hydroxybutyrate. The difference in management of different alcohols depends upon the toxic metabolite formation, which is shown in red. So you can use fomepizole in methanol and ethylene glycol toxicity because you need to inhibit the ADH to prevent the formation of these toxic metabolite. You don't need fomepizole in ethanol or isopropanol poisoning. Try to keep the pH near normal or slightly alkaline using sodium bicarb in methanol and ethylene glycol toxicity. Use folic acid in methanol and thymine and pyridoxine in ethylene glycol to help convert into less toxic compounds. In propylene glycol, discontinue the offending medication. In ethylene glycol, use IV fluid and diuretic to get rid of calcium oxalate crystal in urine. Patients with ethanol and isopropanol toxicity need supportive care only. Think about dialysis in methanol and ethylene glycol poisoning. However, in propylene glycol and isopropanol, you can certainly use dialysis if the patient have severe clinical features. Thank you.